This is Lily. She's a 2.3 kilogram Chihuahua, and she was referred here for a medial luxating patella. So the patella, this is on her left side, is supposed to be sitting where that little hand is there. So this one is luxating, but it's not too bad. So we're going to deal with this one after we deal with this one. So we're going to go ahead and surgically we're going to assess to see if this kind of space here, it's called the sulcus of the trochlea, is deep enough. And if it's not deep enough, we're going to go ahead and we're going to deepen this. And then what happens is her alignment from her quadriceps, which runs from this kind of little bony bridge here and comes down and then goes to the tibial tuberosity. And you can see how that's a straight line there. So that mechanism is, you know, this is congenital as well, but then she also had a traumatic injury on top of it. So what we're going to do is we're going to take where that quadricep and the patella tendon end up attaching down here, and we're going to move it over to the lateral side. And then what that's going to do, it's going to pull that patella over so it's sitting straight within that sulcus of the trochlea here. So it'll be kind of going like this direction instead of that direction. So this here, we end up cutting the bone. So on the side profile, this. So we're going to cut that ridge, and then we move it over to that lateral side, and then we put two K-wires in, and then we do a tension band fixation. So that ends up helping speed up the healing capacity for this osteotomy. Again, that's going to be this portion of the bone down here. Let's see if I can pull both. So this portion of the bone here will be cut, and this is the side view. It'll be cut down like that. Then it's going to be moved over. Then we're going to put two pins in, and then we'll put a tension band. So we'll drill a hole through here, which is this portion here. And then we do a figure 8 tension band wire around these K-wires, and then that holds everything into place so it doesn't pull off, because you have a lot of tension coming from the patella ligament. So the kneecap sitting right up here, that patella tendon's coming down and attaching to the tibial tuberosity. And if you don't go ahead and put a tension band wire, that's just going to pull this bridge right up. So that tension band will keep it from lifting up. And so your forces are acting this way and this way. So you're countering those forces by placing it kind of perpendicular to the two acting forces from that osteotomy. So this is a little Chihuahua. She's 2 years old, and she's 2.3 kilograms. So a tiny little patient. Kind of a finesse surgery. Everything has to be quite accurate with it, but most of this is done kind of freehand during surgery. So there's not a lot of pre-calculations to do on this one. Okay, so feel where that kneecap is.
Over on the side, like right here.
Yeah.
And then this is the sulcus.
You feel it? Yeah.
Down into the joints right here.
So now, and if you flex, you'll be able to feel that patella tendon, which is way over here. So we're gonna really have to lateralize this. So pop it back in. So I'm gonna move this quite a bit over. And that sulcus is
Very shallow.
very shallow. So, but it's got two problems for sure.
Can't rush. No rush, bro.
So feel that divot just below that sulcus. You can feel both of the condyle ridges. And go right in there. It's going to be very shallow.
Okay. And then I'm going to draw back like usual. And I should get synovial fluid.
Right in
Right in the middle.
Right in the overall, it's pretty good. Like that whole patella was sitting basically right here. So the quadricep mechanism was running down the side of the leg. So, and it had no sulcus. So I had to make a sulcus. Then I had to transpose the tibial tuberosity laterally. And then I had to do an imbrication to be able to take away all the excessive joint capsule on the lateral side. So there's basically 3 things that you have to do with that knee.
Wow.
So that's, you know, if you do them when they're a lot younger,
Yeah.
they do very well, and you can actually avoid a lot of the other procedures. But often they're not recommended to surgery soon enough. So you're doing them when they're 2-3 years of age. So, and the patella injuries tend to get worse with age up until about the age of 3 to 4 years of age. So,
Wow.
and then
How
at
old's the
that
dog?
point, you can't do anything about the trochlear groove. You have to deepen it, or you can do a ridge stop. This dog, a ridge stop wouldn't have worked.
So then what happened then? You saw what was happening compared to what you saw here.
Yeah, and then so made a new groove, so deepened it. It's called a box trochleoplasty, and then went ahead and did the tibial crest transposition. So where the patella tendon attaches to the tibia bone, basically you cut the bone there and you transpose it over laterally, so it's making that quadricep mechanism. So in a straighter line, so it sits over the middle of that distal femur rather than it sitting right medial. So we've done our transposition of our tibial crest. That's this part here. So this is our tension band wire with our 2 pins. So we moved that tibial crest that was sitting over here more to the midline. Now we did that sulcoplasty where we deepened the groove. And now we have that patella sitting right nice, dead smack in the center. So if I look up the last one. So this is the prior to surgery. So it's sitting way lateral. And now we're sitting right in the middle.
Oh, it's really obvious now.
Yeah. So now this is going to track up and down properly. Because what would happen is that, and there's no kind of that groove, like that little kind of trough that you get between the distal femur where the patella sits. It was flat. There's nothing there. So I ended up cutting into that, making a deep groove. Patella sits in there. Then we transposed the tibial crest so that it's now that axis for that quadricep muscle, which is attaches up here, is now not so medial. So now it's more this line here. So it's still tracking a little bit, but when we have a grade 4 luxation like this, often we will still have some patella luxation, but it's usually like a grade 1. So if we get no grade, then that's great, but there's still a chance that this can luxate. So, but clinically the dog should be much improved.
And then how's the other side? Was the other side?
Yeah, so the other side has a little bit of a luxation as well, but it's not terrible. So
Well, it's not as bad as the other.
yeah, it's not as bad as the other one.
So will they eventually get the other side done too?
Maybe. So we wait about 8 weeks. We'll see how we do on this side, and hopefully if we kind of fix one side, the other side doesn't have as much strain on it. And then it sometimes we'll go from like a grade 2 to a grade 1. But if necessary, we'll go ahead and we'll do a sulcoplasty on this side. And hopefully we'll only have to do a sulcoplasty on this side, and we don't have to do the tibial crest transposition, but there's still a good chance that we would. So, but yeah, so that was basically pulling from here all the way down like this. So now it's kind of tracking like this. So maybe not quite, it's actually tracking more like.
And did you say earlier that this was like congenital?
Yeah, this is probably congenital. So especially when you actually look at the groove, and this dog has not had that patella sitting in that groove. So during development, you have to have the patella, because the pressure of the patella is actually what forces or what makes that groove to deepen. It's the signal that the body needs, and then it deepens. So if it was sitting out all the time, it's not getting that signal to actually deepen, and therefore you get that kind of flat plateau. So this dog, even though it had a traumatic injury, it's had luxating patella like since it was a baby.
Good for forever, basically.
Yep.
That's it.
Yep, that's it. And sometimes the hardware, especially in these small guys, can be a little bit irritating, and you might have to go out and remove the hardware. But we generally would wait until they're about 8 to 12 weeks after surgery, and then you can actually remove the hardware with no effect. So because the bone's refused and everything. So yeah, and it's a pretty simple procedure to remove that hardware. It takes about 10 minutes. So,
Oh, that's super
and I'd
cool.
probably say with the small dogs, probably 15% end up having the hardware removed.
Oh.
Yeah.
And this is a pretty common thing to happen.
Really common. Very, very common. Sometimes you have so much deformity in the tibia or on the distal femur that you've got this angular deformity, and you have to do what's called a cranial wedge osteotomy. So you basically remove like a wedge on the bone, like a triangular wedge, and you realign the femur so it's straight. So, but there's complications with that, is they take a really long time to heal, and generally you're looking at 5 to 6 months of healing time. So, but sometimes they're necessary. So there's some measurements that you can do that determines that the angle that they have for like any kind of varus or valgus deformity, and then you go ahead and you decide if they need to go and have that wedge osteotomy done. But this dog didn't have an angle. Generally, you look at an angle greater than 12. So this wasn't that high. So tibial crest transposition sarcoplasty is what was indicated in this dog.